A very good afternoon, dear friends. Hope you all are fine. So now today's my topic for the lecture is a applied aspect of the kidney and the diuretics. Okay. So till now we have discussed all the basic physiology of the kidney. So hope you all are clear about the basics of the kidney. Okay. So now just before going to the various disorders of the kidney, just have a brief discussion on the various diuretics. Okay. So you are clear with this term diuretics. Okay. So as these are the substances or any agent that will increase the rate of the urine volume output. That means they are excreting more amount of the urine. So there are various groups of the diuretics that are acting at the various segment of the nephron. Okay, and now most of these substances basically they are used in many of the clinical conditions. Okay, maybe it related to the heart, liver, or anything else. Okay, but as they are acting mainly on the kidney to remove most of the water, so they are discussed here with the kidneys. So now main purpose of this diuretics is to remove the excess of the water. Okay, but primarily they are doing that function by preventing the reabsorption of various solutes from the kidney. Okay, mainly the sodium. Okay, so by preventing the sodium reabsorption they are removing more amount of the sodium from the kidney, and that is known as a natriuresis. Okay, and secondary to that natriuresis the water will not able to reabsorb from the various tubules and water will also get excreted. Okay, so most of the diuretics they are working by this mechanism by preventing the solutes, and then secondarily they are preventing the water reabsorption and removing the most of the water. Okay, so I will discuss the various groups of the diuretics one by one and their various details. Okay, so now first group is the osmotic diuretics. Okay, so as the name suggests, osmotics. Okay, so here the substance that are acting as a diuretics, they are basically working as a osmotically active particles within the renal tubule. Okay, and as you know, the osmotically active particle they will prevent the water reabsorption. Okay, so certain substances like mannitol, urea, sucrose. Okay, so that when they are injected, okay, they can be filtered through the glomerulus, but they are poorly reabsorbed from the nephron. Okay, so they will not reabsorb from the renal epithelial cell. Okay, and they will increase the osmolarity of the renal tubule. Okay, and where they will act as the osmotically active particle and they will prevent the water reabsorption. Okay, and in this way they will remove the more of the water in the urine. Okay, so mainly they are acting at the proximal tubules. Okay, so you know the proximal tubule, it is the part where maximum of the solutes, most of the solutes and most of the waters they are getting reabsorbed from there. Okay, so now one example that you know the glucose. Okay, glucose though it is 100% that is reabsorbed from the proximal tubule. Okay, but if the person who is having a severe diabetes mellitus, whose blood sugar is more than threshold level, okay, more than 200 milligram per deciliter or more than that, okay, then that extra amount of the glucose beyond the threshold, that glucose will not going to be reabsorbed from the proximal tubules or from the nephron. Okay, and that glucose can act as an osmotically active particle and it can cause the polyuria. That means it can cause the diuresis. Okay, so you know the person suffering from a diabetes mellitus, they are having one complaint of a polyuria, means they are excreting lot of the water, they have frequency of the urine, they have to go for a more urination. Okay, so like that these substances are acting by preventing the water reabsorption mainly from the proximal tubule. Next group of the diuretics are the carbonic anhydrous inhibitors. Okay, again these diuretics are again acting at over the proximal tubule. Okay, now you know this term carbonic anhydrous. Basically, it is an enzyme. Okay, that is their main function is to form the carbonic acid from the H2O and the carbon dioxide. So here you can see this is the proximal tubular epithelial cell. Okay, this is the renal tubular lumen, this is the interstitial space, and this is the epithelial cell. Okay, now within the cell, you know the carbon dioxide will combine with the water, to form the H2CO3 carbonic acid. Okay, and that will require the presence of carbonic anhydrous enzyme. Okay, and that carbonic acid will dissociate into H plus ion, okay, and the HCO3 bicarbonate, okay, that is again in presence of the carbonic anhydrous enzyme. Okay, so without this carbonic anhydrous enzyme, the H plus ion will be not formed here, similar to the bicarbonate. Okay, so this is the one thing. Now second thing is, the many of these sodiums that are getting reabsorbed from the proximal tubules, hmm, they are either reabsorbed via this sodium hydrogen exchanger pump, or they are reabsorbed via sodium glucose or sodium amino acid co-transport. Okay, but this carbonic anhydrous inhibitors, they will prevent this pump, this exchanger, sodium hydrogen exchanger, because here the H plus ions are not formed. This pump will not work, this channel will not work. Okay, because this protein will work only when one sodium and on opposite side one hydrogen ion will bind. Okay, but here as there is no H plus production because of this enzyme inhibitors, okay, sodium is not going to be reabsorbed by this mechanism. Okay, so this will prevent the sodium reabsorption from this part of the renal tubules. Okay, so that will increase the osmolarity within this proximal tubule, and secondarily it will prevent the water reabsorption from the proximal tubule as well. Okay, so in this way these carbonic anhydrous inhibitors are working mainly in the proximal tubule. Okay, and most important example of this are the acetazolamides. Okay, so where they are inhibiting the H plus secretion, and they will prevent the HCO3 reabsorption, so reducing the sodium reabsorption. Okay, so now going to the next group of the diuretics, that are a loop diuretics. Okay, as the name suggests, loop here it is means the loop of the Henle. Okay, so these loop diuretics are acting at the thick ascending limb of the loop of the Henle. Okay, so you know about the loop of the Henle, that means the descending portion and the ascending portion. Okay, so descending thin portion basically it is permeable to the water but not to the solute, but ascending portion of the loop of the Henle, it is highly permeable to the solute but not to the water. It is water impermeable but highly permeable to the solutes. Okay, in that case again you can see here the mainly the thick portion, this, okay, thick portion of the ascending limb of the loop of Henle, it is reabsorbing many of the solutes. Okay, and one of the most important pump that is reabsorbing these solutes is this, okay, sodium 2 chloride potassium co-transport pump. Okay, so this carrier protein will reabsorb all these three solutes, sodium, chloride and potassium. Okay, so around 20% or 25% of the solutes are getting reabsorbed from this thick ascending limb of the loop of Mendeleev, mainly via this pump, and also with that there is another pump, that is sodium hydrogen exchanger. Okay, but here our main focus is over this pump, sodium 2 chloride potassium pump. Okay, now this loop diuretics like this furosemide, ethacrenic acid, bumetanide, okay, they are acting at this pump, they are inhibiting this pump. Okay, you can see here they are inhibiting this pump, preventing the reabsorption of sodium, chloride as well as the potassium. Okay, so the main function of this thick ascending limb is to reabsorb maximum of the solutes, okay, and prevent the reabsorption of the water. Okay, so they are basically providing the dilute fluid to the distal portion, but here because of this loop diuretic action this solute will be not reabsorbed, so this portion will provide more of the solute with the water to the distal tubules, and that will secondarily prevent the water reabsorption. Okay, so these are the loop diuretics that are acting at the basically thick ascending limb of the loop of the Henle. The next are the thiazide diuretics. Okay, so thiazide diuretics basically they are acting at the early portion of the distal tubules. Okay, after the thick ascending limb, there is a distal tubules. Okay, so that is again divided into two portion depending on their function, early portion and the late portion. Okay, so this early portion of the distal tubules, okay, where the solutes are reabsorbed, okay, via this sodium chloride co-transport. There is a second reactive transport again, okay, that will reabsorb the sodium and chloride again, and this part again it is impermeable to the water but permeable to the solutes, okay, via this pump. Okay, but these thiazide diuretics like hydrochlorothiazide, chlorthalidone, they will inhibit this pump, they will inhibit this pump, and by that they will prevent the reabsorption of the sodium as well as the chloride. Okay, and so it will again increase the osmolarity, okay, of the distal tubules, and that will secondarily prevent the water reabsorption. Okay, so mainly these thiazide diuretics and this loop diuretics, they are working at the thick ascending limb and the early portion of the distal tubules. Okay, by that they will provide the most solute to the distal tubules and the collecting duct. Okay, and you know the distal tubules and collecting duct, they are permeable to the water in presence of the ADH. Okay, but there has to be more of the water, but here the solutes that are not reabsorbed here, they will be transported to the distal tubules and the collecting duct, where the water will not be reabsorbed because the fluid, it is a hyperosmolar. Okay, next are the aldosterone antagonist. Okay, so now I'm coming to these drugs, these substances that are basically working at the late portion of the distal tubules and also the collecting duct. Okay, now you know that the distal tubules, late distal tubules and the collecting duct, they are having a two types of the epithelial cell. Okay, one are the principal cell and second are the intercalated cell. Okay, so principal epithelial cell, this, they are basically concerned with the reabsorption of the sodium and the secretion of the potassium. Okay, but the intercalated cell, they are concerned with the reabsorption of potassium and the secretion of the H plus ion. Okay, but here these drugs are mainly working over the principal cell. Okay, so this is the principal cell in the distal tubules and the collecting duct. Okay, where there is a reabsorption of the sodium and the secretion of the potassium that you can see here. Okay, so there are two channels, sodium channels and the potassium channel. Okay, where sodium will be reabsorbed, in exchange with that the potassium will be secreted into the lumen. Okay, but these two pump, basically they are dependent on the aldosterone, you know, the aldosterone hormone. Okay, that are having receptors over here, over these cells. Okay, so aldosterone will bind with the receptor and it will increase the permeability of the sodium and the secretion of the potassium. Okay, but the aldosterone antagonists, basically this type of the drugs like a spironolactone, they will compete with the aldosterone receptor over these principal epithelial cells. Okay, so where it will not allow the aldosterone to act. Okay, and by that it will decrease the permeability of these two channels. Decrease sodium reabsorption and also it will decrease the potassium secretion. Okay, so by this, by preventing those sodium reabsorption, again it will secondarily prevent the water reabsorption as well. Okay, so these drugs, they are indirectly preventing the sodium reabsorption, okay, and causing the natriuresis. Okay, so now here you can see they are working here. So they are preventing the sodium reabsorption, but they are also preventing the potassium secretion. Okay, so otherwise normally with the reabsorption of sodium there is also loss of the potassium, but here these drugs will prevent the potassium secretion, so they will preserve the potassium in the body. Okay, so that's why these drugs are also known as a potassium sparing diuretics. Okay, they will spare the potassium. Okay, and a similar type of the drugs that are known as a sodium channel blocker, they are again acting over these channels only. Okay, but the only difference between these two drugs is that aldosterone, they are indirectly preventing the sodium reabsorption, but this sodium channel blocker, they are directly blocking this channel only, irrespective of the status of this aldosterone. Okay, and by directly blocking this channel, they are preventing the water reabsorption and potassium secretion. Okay, and they are causing the natriuresis and secondarily diuresis. Okay, so these spironolactone, that are aldosterone antagonists, and the sodium channel blocker examples are amiloride and the triamterene. Both they are preventing the sodium reabsorption and the potassium secretion at the distal tubules and the collecting duct by acting over the principal cell. Okay, and both are called as potassium sparing diuretics because they are preserving the potassium here. Okay, so same the sodium channel blocker that are only working like this. So this is the summary of all these various groups of the diuretics, various classes of the diuretics. Okay, just you can go through, already we have discussed all the things: osmotic diuretics, loop diuretics, thiazide, carbonic anhydrase inhibitors, aldosterone, sodium channel blocker. Okay, so all that just you can see that. Okay, so these are the important groups of the diuretics. So various drugs that are acting as a diuretics by acting at the different segment. Okay, and depending on the conditions, these various diuretics are used. Okay. Now, other than this, there are certain other substances that can also act as a diuretics that can increase the urine outflow. Okay, so out of one is the water. If you are drinking excess of the water, then there will be a more urination. Okay, so the excess of the water, okay, it will inhibit the ADH secretion. Okay, by making the plasma volume hypotonic. Okay, and as you know, the water reabsorption from the distal tubules and the collecting duct, it is mainly dependent on, or it is solely dependent on the ADH, antidiuretic hormone. Okay, so if the ADH are present in adequate amount, then the water will be reabsorbed. But if ADH are less, then water is not going to be reabsorbed from this portion, distal tubules and the collecting duct, and it will cause the diuresis. Okay, so excess of the water in the body, okay, it will decrease the ADH secretion from the posterior pituitary. Okay, and it will decrease the reabsorption of the water from a distal tubules and the collecting duct. Second is the alcohol, similar way. Alcohol intake, okay, it will also inhibit the ADH secretion and it may cause the diuresis. Okay. Then the glucose already we have discussed. That means if there is excess of glucose, mainly seen in the severe diabetes mellitus, okay, where the many of the glucose are not able to reabsorb from the proximal tubules and they will act as osmotical active particle and they will prevent the water reabsorption. Okay. Then caffeine, it may also act as a diuretic by increasing the GFR and by decreasing the renal tubular sodium reabsorption. Okay, so these all about the diuretics. Okay, various group of the diuretics, various examples of that groups where they are working. Okay, so now coming to the various disorders related to the kidneys. Okay, applied part of the kidney. So here first we'll discuss about the, okay, certain common symptoms related to the kidneys. Okay, so we have to discuss this applied part under three headings. Basically, one are the common urinary symptoms, second is the renal failure, that is the most important portion, and third one is the nephrotic syndrome. Okay, so first, so certain common urinary symptoms, okay, that is complained by the patient. Okay, so we'll discuss again in briefly one by one. Okay, so one is the polyuria. Okay, poly means more and urea means urine. Okay, so if the person is having a excess of the urine volume output, then person, that is known as a polyuria. Okay, so normally, you know, if the person, adult person, healthy adult person under a physiological condition is, he or she is excreting around 1 to 2 liter of the urine per day. Okay, but if this urine output per day it is more than 3 liter, then it is called as a polyuria. Okay, so which may be a physiological, it may be a pathological. Okay, so just have a see here. Physiologically, it may be due to the primary polydipsia. If you are drinking excess of the water, it may lead to the polyuria. Okay, sometimes it may be a psychological, psychogenic, or it may be drug induced. Certain drugs are having an adverse effect that may cause the diuresis. Okay, and the pathological conditions that will lead to the polyuria, the most common condition, you know, it is a diabetes. Okay, whether it is a diabetes insipidus or a diabetes mellitus. You know both the terms. Okay, diabetes insipidus already we have discussed previously. Okay, so where there is a excess excretion of the water, excess urine volume output. Okay, so diabetes insipidus, it may be a central or nephrogenic. Okay, so mainly here there will be a decreased reabsorption of water from the distal tubules and the collecting duct. Okay, either due to the deficiency of the ADH hormone or the decreased sensitivity of the receptors present over the epithelial cell of distal tubules and the collecting duct to the ADH. Okay, so depending on the, we have discussed the central diabetes insipidus, nephrogenic diabetes insipidus. Okay, so that is the one, and second is the diabetes mellitus. Okay, if there is a glucose level in the diabetes mellitus more than threshold, then it may lead to the polyuria. Okay, then second symptoms are the dysuria and the urgency of the micturition. So now dysuria means it is a pain during the micturition or it is a burning sensation during the micturition. Okay, so that is a dysuria. And second is urgency means exaggerated sense or a urge to micturate. even though the bladder is not completely full, but there will be a urge to go for the urination. Okay. So most common causes of this dysuria or urgency of urine is the inflammatory or infective condition within the bladder or the urethra. Okay, so if there is an infection because of which there may be inflammation within the bladder or in the urethral portion, then it may lead to this condition. Okay, so that may be due to an infection, or many times it may be due to the stone. If there is a small stone is present within the bladder, that it may lead to the irritation there, and it may lead to the urgency or the burning during a micturition. The next is the incontinence. Incontinence means inability to retain the urine in the bladder. That means there will be involuntary excretion of the urine. Okay, most of them there is the dribbling. We have discussed previously again during the micturition portion. Okay, so where patient will not able to hold the urine, it will flow. Okay, so that may be because of the various causes like a neurogenic stress incontinence. It may be mechanical, it may be overflow, it may be functional. Okay. Next one is the enuresis. That is also known as a bedwetting. You may also call it as a nocturnal enuresis. Okay, so physiologically it is seen in the children's, but many times it is also seen in the older children's or in the adult as well. Okay, so there is a basically involuntary passage of the urine at a night or during sleep. So most of the time this is seen during the sleep, and most of them we are sleeping in the night. Okay, so this is also called as a nocturnal enuresis. So another terms are anuria and the oliguria. Olig means decrease and means near to the absence. Okay, so now you know that our kidney can excrete severe dilute urine, or they may also excrete a severe concentrated urine depending on the need. Okay, but the minimum amount of the urine that must be excreted by the kidney, that is known as the obligatory urinary volume, that we have discussed previously again. Okay, so this obligatory urinary volume, it is around 500 ml per day. That means the adult person must excrete around 500 ml of the urine per day. Okay, that their kidney must excrete this amount of urine, that is obligatory, that is known as a minimum. Okay, but if person is excreting the urine volume less than that obligatory, okay, then that condition is known as oliguria. Okay, so if the person urine output is less than 400 ml per day, okay, then it is known as a oliguria. Okay, and the most common cause of that oliguria, it is a acute or a chronic renal failure. Okay, so oliguria or the anuria, they are always pathological. Okay, okay. Second is the anuria. Anuria means almost very little passage of the urine. If the urine excretion is less than 100 ml per day in adult person, then it is known as a anuria. Okay, so again it may be due to various causes. Okay, it may be due to the conditions that are given here. Okay, so common conditions are a completely obstruction to the urinary passage, maybe it at the ureter level, maybe it as a bladder level or through the urethra. Okay, so complete urinary tract obstruction due to the stone or any other conditions, total bilateral renal arterial or venous obstruction that will block the blood supply to the kidney. So there will be a no GFR. So that will lead to the decreased or anuria. Okay, bilateral renal cortical necrosis, or it may be due to the glomerular nephritis. So these are the certain symptoms or certain common urinary symptoms that are complained by the patient. Okay, if there is any because of certain various disorders. So now coming to the next important portion of this applied aspect are the renal failure, kidney failure. You are aware about this term, kidney failure. Okay? So kidney failure means there is a deterioration of the renal function that will result in the decrease in the GFR, and because of that there will be a rise in the urea and certain other waste product that has to be removed by the kidney. Okay, now you know the main function of this kidney to remove the waste, to remove the waste, mainly the urea, creatine or any other NPN substances. Okay, but if there is a renal failure, then the kidney will not able to remove this waste and they will be accumulated into the body, and it may lead to the various complications. Okay, so now renal failure, it may be acute or a chronic. Okay, two types of the renal failure, it is acute and the chronic. Okay, So the acute renal failure, first we'll discuss. Okay, so it is a sudden decrease in the GFR with rapid rise in the blood urea and also the blood creatinine level. Okay, sudden. Okay, it may within the few days or within a few weeks. There will be a complete decrease in the GFR, so that will lead to the increased amount of this waste product in the blood. Okay, so mainly the urea and the creatinine. So this acute renal failure, it may be due to the various causes. So we can divide that causes, okay, as a pre-renal, intrarenal, or the post-renal. Okay, pre-renal means the cause is outside the kidney. Okay, kidney is not the directly cause. Okay, second is intrarenal means the condition pathology is within the kidney. That's why the kidney is not working. And third one is the post-renal, means beyond the kidney, maybe it in the ureter or maybe due to the cause in the bladder or the urethra. Okay, so just we'll have a brief over this various causes. Okay, so the pre-renal acute kidney injury, that is mainly the pathology is outside the kidney. Okay, and the main cause for this, it is the obstruction to the blood supply of the kidney. Okay, decreased blood supply to kidney, any causes, any pathology that may lead to the decreased blood supply to the kidney, it will lead to this acute kidney injury or acute renal failure. Okay, so it may be again grouped as a first common cause are the intravascular volume depletion. That means there is a severe decrease in the plasma volume. Okay, that may lead to the decreased blood supply to the kidney. Okay, so it may be due to severe hemorrhage, it may be due to the severe diarrhea, vomiting, it may be due to the burns. Okay, all these causes will ultimately decrease the plasma volume severely. Okay, and that will decrease the blood supply to kidney and decrease the GFR. Okay, second, the cardiac failure. Cardiac failure again, it may lead to the decreased cardiac output, and that will decrease the urine out plasma volume and decrease the blood supply to the kidney. Okay. Then certain other causes like peripheral vasodilation or the severe hypotension. Okay, that may be because of a anaphylactic shock or a anesthetic complication. It may be due to severe sepsis, that means a severe infection in the body. Okay, like that. The second causes are within the kidney. Okay, problem it is within the kidney. Okay. So in that case, again, there are various groups that you can see here. Okay, glomerular injury or tubular epithelial injury. It may be a renal interstitial injury. Okay, so cause may be anywhere within the glomeruli or within the tubular epithelial cell. Okay, or within the interstitium. Okay, but the most common cause again here, that is highlighted here. You can see this acute glomerulonephritis. That is the most important and the common cause of this acute renal failure. Okay, as far as the pathology within the kidney is concerned. Okay, so glomerulonephritis basically it is causing the inflammation or damage to the glomeruli. Okay, so primarily the cause is an infection, bacterial infection elsewhere in the body. And the most common infection is the streptococcal infection. Okay, so that infection elsewhere in the body, that may lead to the production of the antibody against that antigen for that particular bacteria. Okay, so that antibody and the antigen for that bacteria, that will react and they may form the uh, what you can call it as a blocks, and that clots, that will block the blood supply to the kidney and they will affect the glomeruli. Okay, so in that way the glomeruli will be affected and they may be damaged, may become a non-functional. Okay, and that will cause the renal failure. Okay, so the various other causes that are highlighted here that you can see. Then the post-renal causes. That means the causes are within the renal system but not within the kidney. Okay, so it may be within the ureters, or the cause may be within the bladder, or it may be the urethra. Okay, so the obstruction to the ureters, both the ureters, at the pelvic level, that means within the renal pelvis or throughout the course. Okay, obstruction to both the ureter, it may lead to the renal failure. Okay, then the bladder obstruction, mainly it is due to the stone. Stone, it will obstruct the bladder, then it may again cause the damage to the kidney. Okay, and third one is the obstruction of the urethra. Okay, so these are the various causes of the acute renal failure. Okay, so now what may be the complaint or what may be the sign and symptoms of this acute renal failure? Okay, so first is the oliguria or there may be anuria. Hmm? Patient's urine output will be less than 400 or less than 100 ml per day, even though the intake is normal. Okay. Then there may be edema and the hypertension. Because the kidneys are not excreting the urine, they are not excreting the water, there will be increased plasma volume that may cause the leak of the blood fluid into the interstitial space, and that may lead to the swelling. Okay, swelling in the various part of the body, and that is known as the edema. Okay, similarly, because of the increase the plasma volume, it will lead to the hypertension as well. Third are the rise in a blood urea and the creatinine level, because these are the two important waste products that must be removed by the kidney, but because the kidneys are non-functional, they will not able to remove that. Okay, because glomerulus are not working, so they will not able to filter this waste product into the renal tubules. Okay, so this will be accumulated within the blood. So if you test the blood, okay, then the blood urea, okay, serum urea or the serum creatinine will be high than the normal. Okay, then the high urine osmolality. Okay, then hyperkalemia, okay, and the metabolic acidosis. Okay, so these are the certain characteristic features of the acute renal failure. Then just brief about the management, how you can treat this type of the patient. Okay, so the first and foremost treatment is the symptomatic, depending on the symptoms. Okay, one is to maintain the water and the electrolyte balance within the body. If there is an infection, then you have to control that infection by giving the antibiotics or anything else. Then blood pressure, if there is hypertension, then control the blood pressure. Then the renal failure may lead to the severe metabolic acidosis, and accordingly you have to treat. Okay, then control the diet. Means try to decrease the protein diet. Okay. Second choice is the dialysis. If the patient is not maintaining on that, then there may be a need of the dialysis that we will discuss later on. Okay. And third one is, if the patient is not responding to this type of management, medical and the dialysis, then that patient may require the kidney transplant. Okay. Second is the chronic renal failure. So where there is a progressive and the irreversible loss of the functional nephrons. Okay, so gradually the kidney will lose the functional nephron. Okay, and if the functional loss is more than 70 or 75%, then person may need immediate renal transplantation, otherwise person may die. Okay, so here the person may develop the uremia. Uremia means accumulation of the various metabolic waste product into the blood body. Okay, so the concentration of this various metabolic waste product, urea, creatine, or anything else, they will increase in the blood. So this is basically manifested by the excretory, metabolic, neurological, hematological, or certain endocrinal abnormalities. Okay. So various causes just that are highlighted here. We will not go in detail about that. Okay. So certain metabolic disorder, mainly the diabetes mellitus. Okay. Uncontrolled diabetes mellitus may lead to this. Okay. Severe uncontrolled hypertension may lead to this. Okay. Other causes are glomerulonephritis, pyelonephritis, certain drugs that are known as nephrotoxics. Okay. Then chronic urinary tract obstruction, certain congenital disorder that may all may lead to this chronic renal failure. Okay. Now, once the patient is in the chronic renal failure, then there'll be a vicious cycle that will aggravate that failure. Okay. So just you can see this uh, chart here, this cycle. Okay. So because of the any primary kidney disease, there is a decrease in the functional nephrons. Okay. So that may lead to the hypertrophy and the vasodilation of the surviving nephrons, because the work of that non-functional nephron, it has to be done by the remaining functional nephron, so there will be hypertrophy and the vasodilation. Okay, with that there will be also increase in the arterial pressure, blood pressure. Okay, both this may lead to the glomerular uh, okay, increase in the glomerular pressure and the glomerular filtration. Okay, and this will ultimately lead to the glomerular sclerosis. Okay, and once this glomerular sclerosis is found, then it will increase this damage. It will further stimulate the loss of the functional nephron. Okay, so once this chronic renal failure begins, then there will be vicious cycle, and the patient may urgently require the renal transplant. Okay, So management, the primary management is to control the various symptoms: blood pressure, diabetes, diet, okay, blood volume, acidosis if there is, okay. But the final treatment here is the dialysis, and the permanent treatment it is the renal transplant, okay. So the once chronic renal failure is provoked, then patient may live on the dialysis, but that is not permanent solution. Patient must be have a renal transplant for a long life, okay. Okay, so these are the renal failure. Okay, third important abnormality of the kidney is the nephrotic syndrome. Okay, more commonly it is seen in the children's, younger children's. Okay, so in the nephrotic syndrome, there will be a massive proteinuria. That means there will be loss of the plasma proteins in the urine. Okay, so the proteinuria it may be more than 3.5 gram per day. Okay, and mainly it will include the albumin. Now we have discussed that the plasma proteins that are normally not filtered through the glomeruli. Okay, glomerular membrane it is not permeable to the plasma proteins. So normally urine doesn't contain the proteins. Okay, that is not containing the plasma proteins. Okay, proteins may be present, but that are not plasma protein. Okay, that is under normal conditions. Okay, but in the nephrotic syndrome, there will be a severe proteinuria. There will be filtration of the plasma proteins through the membrane, and they will be excreted in the urine. Okay, so here this syndrome it is associated with the hypoalbuminemia because the plasma proteins will be filtered and they'll be excreted. So there'll be decrease in the plasma protein within the blood, and mainly it will be the albumin. Okay, because albumin, then there'll be edema. Okay, because this plasma proteins they are important oncotic pressure because of the plasma it will prevent the uh, excess of the fluid within the interstitial space, okay. But if there's a loss of the plasma proteins then it will decrease the oncotic pressure and that will create the increased interstitial fluid and that may lead to the edema, okay. Then hyperlipidemia, lipiduria, hypercoagulability, these are the symptoms or the characteristics that are associated with this nephrotic syndrome. So just here you can see this pathophysiology of this nephrotic syndrome, okay, where the primary there is a glomerular injury. Okay, so here the glomerular injury because of any reason it will lead to increased permeability of the glomerular membrane that may also permeable to the plasma proteins. Okay, so this glomerular injury it will lead to increased urinary protein loss. Okay, and with that there will be inadequate hepatic synthesis of the proteins, so there is a protein loss and decreased production. So both this it will lead to the hypoproteinemia, mainly the decreased albumin level, so that is hypoalbuminemia. Okay, so that will decrease the oncotic pressure and because of that there will be edema. Okay, collection of the fluid, excessive collection of the fluid within the interstitial space. Okay, and second thing, this hypoalbuminemia it will lead to increased synthesis of the LDL and the cholesterol that may lead to the hyperlipidemia and the lipiduria. Okay, so this is about the nephrotic syndrome. So this is all about the various disorder of the kidney, important disorder, not all the disorders. Okay, so now coming to the one most important term, there is the dialysis. You have heard this term dialysis. Okay, so dialysis means there is a diffusion of the solutes from an area of the higher concentration to the area of a lower concentration through a semi-permeable membrane. Okay, so dialysis may be of a two type: hemodialysis and the peritoneal dialysis. Okay, but as far as this renal failure patients are concerned, the hemodialysis is most commonly used. Okay, so here you can use the term hemodialysis as well. Okay, so just you can see here this picture you can see. Okay, so this is a dialysing unit. Okay, where here this unit contains the semi-permeable membrane. Okay, and these are the dialysates that are containing the fluid with a specific composition. Okay, so here what this dialysing unit is doing, it is basically acting as the artificial kidney. That means here the normal kidney is not working, so that removal of the waste product it will be done by this dialysing unit, dialyzer. Okay, that is also known as a hemodialyzer. So you can see in this figure, okay, here the blood that is taken out of the body it will pass through this dialyzer. Okay, within this there is one tube that is acting as a blood vessel. Okay, and that is having a membrane. Okay, that is having a semi permeable membrane, okay, that will allow to pass only certain substance, okay, and then that once this blood will pass through this unit, it will be again returned to the body, okay. So now basically uh, this is needed when there is a severe loss of the kidney function, okay. So now basic principle of this dialysis is that, okay, here the blood is passing through the minute channels through this portion, okay, through this membrane, okay, and on either side there is a dialysing fluid on this membrane, okay. So now this dialysing fluid contains the composition that will not have the plasma proteins. The composition is not same as that of this blood, okay, but it is basically maintained depending on the need, okay, depending on the removal of the metabolic waste product, okay. So here the blood, when it is passing through this membrane, okay, so this membrane will remove the all the metabolic waste product that are not present here but they are present within the blood, okay. So the high concentration of this metabolic waste product will be removed from the blood into the dialyzer, okay. So here you can see two portion, one is in and one is out. Here the dialysing fluid that is going within this portion, and once this the metabolic waste product from this portion is removed, that dialysing fluid will be exited via this portion, okay, and this blood that will pass through out of this dialysing unit, it will not contain the metabolic waste product that are removed from this portion, okay. So you can see here also, okay, this is the this portion is working like a blood vessels through which the semi outer side of that the semi permeable membrane is present, through which the metabolic waste product will be removed, or any excess product within the blood, it will be removed, okay. So just this is the brief comparison of the normal plasma in the healthy person, then the composition of the dialysing fluid, and the composition or the concentration of the various substance in the person who is having a chronic renal or acute renal failure with a uremia. Okay, so this completes the today's lecture. Okay, thank you very much for listening. Okay, so this completes the applied aspect. So in the next lecture of this renal physiology, I will take the lecture on the renal function test.